Hello, and welcome to the Innovation Forum AI podcast, a space where we explore how artificial intelligence is transforming public health. In today's episode, Yannis Paschalidis from Boston University shares how artificial intelligence is being used to predict public health outcomes. We also discuss an initiative that Yannis is working on called Beacon, a global network of infectious disease specialists who detect outbreaks. Yannis describes how Beacon also uses an LLM called Pandemic IQ, which they developed especially. Throughout the conversation, he emphasizes the need for human oversight and the importance of embracing AI critically and responsibly. Welcome, everybody. My name is Oliver Morgan, and our guest today is Yannis Paschalidis, a distinguished professor of engineering and director of the Hariri Institute of Computing at Boston University. He also leads the Beacon project, an AI-powered system for detecting and reporting emerging disease threats. With a PhD from MIT, Yannis has authored over 300 scientific papers and is internationally recognized for his work in artificial intelligence, computational medicine, and data-driven public health. Welcome, Yannis. It's great to have you on the podcast.
Thank you, Oliver, and it's a pleasure to be here. Let me also perhaps take a moment to say that Beacon that you mentioned is a team effort, is a large project, and is led by Nahid Badilia, and we have been collaborating with Nahid for a number of years now, and other very important people on the Beacon development side are Britta Lassman, who is an infectious disease doc, and leads the subject matter expert group for Beacon, and John Brownstein is with Boston Children's Hospital, and his health map team are part of the Beacon effort.
Thanks, Yannis. And we actually had a chance to meet in Berlin a few months ago, actually, with Nahid. And by coincidence, I was actually talking to John just before with this podcast recording. So very close collaborators with the whole team at Beacon. And we'll definitely get into the topic of Beacon as we get through that conversation. But I was wondering maybe if you could start just by describing how you went from electrical engineering, which was your first degree, and how you ended up getting into data science, AI, and now public health.
Yeah, thank you, Oliver. Well, I think the first factor is that I live in Boston. And Boston, as you know, is a mecca for healthcare-related research. There are plenty of research institutions here in Boston, large hospitals. So it's natural, and there is a large group of collaborators that one can tap. I thought that computational biology and healthcare are a really great domain to work on. And I guess one observation is that, they are obviously becoming more data-intensive domains, and a lot of the data is now available in digital form. That was not the case 20, 30 years ago. And I think this creates opportunities to apply algorithmic methods. And I thought that there was a gap that people like me with my expertise could possibly fill and contribute to this large field. I guess you can also go back in history, perhaps, the field of biomedical engineering emerged as a spin-off of electrical and computer engineering, initially with instrumentation, and later with, work in molecular engineering, proteins. So these are more recent developments, but some of the early origins of biomedical engineering are in electrical and computer engineering.
Wow, that's great. And so I guess keeping up a tradition of using data and technology in the medical field, I've seen some of your publications, and I know that you've done quite a bit of work on using AI in electronic medical records and helping, I guess, gain insights from that. Could you tell us a little bit more about some of that research?
Yes. So we have done a number of different studies. Initially, we started looking at problems that relate with chronic diseases. and we wanted to understand and build predictive models of hospitalization due to chronic disease, cardiovascular disease, diabetes, were some of the diseases we looked at. And then when the pandemic came, I guess many of us were stuck at home, working remotely with my team, with my research team, and like everyone, we thought how we could contribute to the pandemic effort. And at the time, we started looking at electronic health records of people that were infected with the virus. And we, in collaboration with others in the Boston health ecosystem, we tried to develop some models that were predicting hospitalizations for those that were infected, but also level of care requirements for those that ended up in the hospital. So we developed some models that were predicting whether someone hospitalized will need to get care at an ICU, whether someone will need to be intubated, and that was at the time useful because, as you can obviously remember, there was a lot of discussion about lack of resources and how to better staff and how to better plan ahead for the journey that the patients would need to take within the hospital.
And how has this kind of matured? I mean, presumably you use this during COVID-19. Has it produced some more kind of generalizable approaches that you've been able to use in Boston for other diseases?
So when we got into the field of looking at electronic health records, something that we observed is that there's quite a bit of noise, and there are sort of many samples that one would consider as outliers. And oftentimes these types of samples, in fact, skew the model to the point where the model perhaps will make more errors when you are going to apply to a new data set. So that motivated us to do some methodological work. And one of the frameworks that we developed as part of this effort is what we call distributionally robust learning, which is a form of learning that to some extent doesn't trust the probability distribution that is induced by the data set, and is looking to introduce a model that can be robust to additional levels of noise, to some outliers that may exist in the training data set, or even to sort of mismatches between the training data set and the data set where the model is going to be applied. And that framework is very general. And we have since then applied it to a number of different settings. I'll give you some examples. We have done, for instance, some work in predicting pregnancy outcomes, predicting EIVF outcomes, predicting some health conditions that may potentially inhibit fertility, things like polycystic ovary syndrome, which is one of those conditions that may inhibit fertility and also would have long-term health implications for the women that have it. And also we have done some work in the brain aging space. We're very much interested in assessing Alzheimer's disease, related dementias, and also even develop models that would be able to predict the future cognitive status of patients that potentially now may show only very mild form of cognitive decline. We're interested in understanding whether we can come up with a model that would predict transitions to more severe forms of dementia, or whether these patients will remain stable for quite some time. Because this affects the way you would treat these patients and potentially opens the door to interventions that can be introduced that have obviously an effect of trying to mitigate the condition.
It's incredible. The AI approaches that you've been developing are really unlocking insights in just a huge range of different health fields. I was curious, when it comes to applying some type of AI approaches for electronic health records, do you have to take specific approaches for each different hospital system, or is there some degree of, I guess, tailoring the approach to the different hospital system, or can you just apply a generic approach to every hospital system without too much specific changes?
Yeah, of course, we train the models given the data we have, and most of the times the data are coming from one hospital system because it's fairly complicated to be able to get access to data sets that involve multiple hospital systems. In some instances, for instance, for the Alzheimer's work, we've been able to get data from multiple studies. And you can, in those cases, do what is known as external validation. So essentially, you train the model based on one data set, and then you are trying to see how well the model is performing on a different data set that may be coming from a different hospital system. One, I think, advantage is that there is perhaps now more homogeneity in terms of the electronic health record systems that different hospitals are using. There are some market leaders in the US where a very large percentage of hospitals are using the same vendor, which make it easier to develop models in one system and then go and apply it in a different system. Of course, even in those cases, even the vendor where the health records may be stored is the same. There are maybe differences in the way they treat the different fields, different hospital systems. And I think that's where a lot of the robustness techniques that we have developed come and become useful in sort of learning models, training and learning models that could be applicable beyond the specific system and data set that you have used to train the model.
And Yannis, these are not just off-the-shelf AI models like ChatGPT, right? These are specially designed by you and your team, or what is that process like?
Yeah, so a lot of the work that we have done in the past and even now involves custom-made algorithms. Essentially, think about general regression, classification type of problems with a lot of care in terms of selecting the right features that will be included in the model. And there are methodologies that help you do that. And also care in the way you train the model. I mentioned some of the robustness methods. In terms of, the more recent generation of LLMs, I think what they have changed is the way that one could possibly handle text inputs. In the past, and even for our work during the pandemic, for developing this level of care requirements for COVID, we had to develop very special custom-made natural language processing pipelines because sometimes the data that you need are not extracted and they are in clinical notes, and one has essentially to read and understand the clinical note and extract the right information to use to train the model. At that time, we developed a special natural language processing pipeline. So this now has become much easier with the emergence of the large language models. And in some of the most recent work, we are leveraging these large language models to read text, to extract the important information that is needed. But then down the line, we need to develop special purpose models. It's not necessarily... LLMs are not designed to ask them to develop a model that has certain properties and is predicting something or is making recommendations for a specific treatment.
So really the models are developed and kind of tuned especially to the settings in which you're deploying them, rather than they be kind of these generic models that you can just plug and play.
Yes, that's correct. I mean, there are by now lots of libraries that you can use. So it is in some sense plug and play, but it is, very deliberate plug and play and picking the right libraries. and also intervening and adding terms and penalty functions that are important in developing any particular model. And of course, making decisions, what are the right features, what is the right pipeline, what is the right way of looking at the data, of encoding the data, of leveraging the data in order to train a specific model.
Great. Well, maybe we can jump into an example which you mentioned at the beginning of the podcast, and which is actually how you and I actually met, which is the Beacon initiative. It'd be great to understand more about Beacon itself, and then also, we can, I guess, understand how this model training, model adaptation process is used for a public health purpose of detecting new public health threats. But why don't you give us a kind of introduction to Beacon and what it is and how it works?
Yeah, so Beacon is a disease reporting system, an outbreak reporting system. And the way it works is you can think of AI agents that are essentially looking throughout the World Wide Web for any story that gets published that reports a specific outbreak. Then this is in fact work that is done by our health map collaborators at Boston Children's Hospital. Then, this generates many, we call them signals during a day, perhaps on the order of 1,000 signals during the day. There's a bit of filtering that gets done, and also there is filtering that is done by humans. So we have a large network of subject matter experts that are looking at the signals and are making decisions. What are the important signals to analyze and report on? So these are editorial decisions, and humans are helping making these decisions. And then once some human decides that it's important to report on a specific outbreak, then there is an AI pipeline that works alongside that human expert. So many of the more mundane tasks that a human would take significant amount of time to do are now performed by AI. There is a large language model that we have specifically trained for that purpose that is much more knowledgeable about infectious diseases, in general about priority pathogens, about the type of outbreaks that one would typically encounter. And the reason that we had to train our own custom LLM is because the generic commercial LLMs do not necessarily have the context. You can think about how these generic commercial models are trained. They are trained in pretty much everything that exists out there, but the percentage of infectious disease context in their training data set is rather small, right? So you are interested in training a model that has gone to medical school in many ways and understand much more about infectious diseases. So that model extracts important information from the report that we found. It will assess whether there is urgency in terms of publishing the report, would assess the quality of the report, will even provide the risk score that is used as a guidance for the human experts. The human experts will augment that report, will edit it, will correct it. There is a draft that the AI is writing, but then the human experts will go and in some instances significantly edit that draft, and they will make a decision, ready, publish it, then it appears on the Beacon website, and I'll put a plug in. So the Beacon website is beaconbio, one word, .org, and is a system that is now quite heavily used. We have more than 1,000 users. Was launched in April of this year, and since then there have been more than 1,000 reports that have been produced on the order of 130, 140 outbreaks in many different countries and territories.
Wow, that's great. Yeah, we'll definitely put the link in the show notes so that listeners can go and have a look at Beacon. It's completely free for people to access, which is really amazing. And as somebody, myself who's worked in this space for a long time, like I know how much work goes into some of the manual processing that you've really been able to automate and have the AI model help with. And it's really interesting to see the strategy or the approach of Beacon as not replacing people with an AI model, but using AI to enhance and facilitate a lot of the human work as well. That sounds like a very deliberate design feature of Beacon. Is that right?
That's correct. And I think through our past experience, perhaps a realization is that AI is great, but it needs human supervision. And that's a very important aspect. And from the very beginning, that was the approach that we decided to take with Beacon. So AI is smart, can exploit different pieces of hidden information, but it has flaws, it has limitations. LLMs can hallucinate. AI models and machine learning models that you can train, they could leverage hidden information in the data and potentially accentuate biases that exist in the data. So human supervision is important, and for Beacon specifically, anything that gets published on the Beacon website has been looked at and has been edited and has been verified by a human, and there is a human that stands behind the correctness and accuracy and veracity of that report.
Yeah, that's really interesting. I think a lot of people are, I guess it's a bit of confusion out there about what AI can do and whether it's there as a replacement technology or if it's there to enhance the work that we do. So it's really interesting to hear that. And I think that's something that we'll probably see more of like the special design elements of humans plus AI rather than humans instead of AI. One of the features of Beacon that we've discussed, you and I have discussed previously, is actually your AI model, your LLM, is actually, as you mentioned, specifically designed. And if I remember correctly, it's called Pandemic IQ. Is that right? And maybe you could explain how you go about training an AI model, what you put in there, how much effort does it take? Is it something you can do on a laptop, or is it something you have to do on a supercomputer? Maybe kind of explain a little bit how that works.
Yeah, so there we actually don't start from scratch. So we started from an open source model. In fact, we started from the Llama family of models that have been made available by Meta. And it's important to start from some generic good model starting point because this is an extremely computational intensive effort to train a model. And these are fairly large models. So we have trained models that have 8 billion parameters. We have also trained models that have 70 billion parameters. So these models are trained using, in fact, many GPUs. When we trained the model that is now being used as part of Beacon, we had access to a cluster of 32 GPUs, and that's where we trained the model. In the process of training, or it's called fine-tuning many times in the computer science literature, a model involves two steps. The first step is you collect lots of documents that are very much related to the domain where you are interested in applying the model. And in our case, we collected more than 50 gigabytes of data that included many papers, about, in fact, 500,000 papers from PubMed that were related to infectious diseases, priority pathogens, clinical guidelines for the types of diseases that we expect to encounter in these various outbreak reports. Many books, maybe on the order of 6,000 books that were available, publicly available, and also other documents from trusted sources, including WHO, including US CDC, many regional CDCs. So that corpus of 50 gigabytes was used to essentially ingest that knowledge into the generic LLM. The second aspect of the training involves instruction tuning, as it's called in the computer science literature. And instruction tuning essentially it means that you are, again, improving the model, you are changing and optimizing the parameters of the model in order to make it work really well in the very specific set of questions, types of questions that you are going to be asking the model. So you don't need the model to be able to solve a sophisticated differential equation, right? But you need the model to be able to do really well when you ask it questions that relate to infectious diseases, that is able to, for instance, provide a risk score for a specific outbreak. So that process of sort of specializing the model and making it perform very well essentially involves providing many examples from past outbreaks of questions and then ideal answers to those questions, and then train the model to essentially be able to provide the same level of quality as these ideal answers that you have provided. And these ideal answers may come from other models or from a variety of other really good, much larger models than the model that we were interested in training, but also can be provided by humans. And in fact, an interesting aspect, I think, of Beacon and our aspirations for the future is now that we are collecting more and more data from the subject matter experts, from the infectious disease professionals that are interacting with the model, we understand much more how they are using the model, where the model is more weak, and that data could be used in order to train better versions of the model in the future, essentially in an effort to try to reduce the amount of work that the human experts are doing.
So this is the idea of reinforcement learning, right? Where the model's kind of learning from how the humans are interacting with it, and then you can, I guess, continue to train the model and make it stronger and more relevant to the users.
This is what people call RLHF, which stands for Reinforcement Learning from Human Feedback. And essentially, you are using the feedback from the humans as some form of a reward. And when a human is satisfied and doesn't make many changes to what the model has produced, then you can think of this as rewarding the model for this type of output, where in other cases where the human would make many modifications to what the model has produced, then you can use that as sort of a penalty for the model. And through that process, you are evolving the model to try and be better aligned with what the humans are looking for.
And you mentioned that the model, the pandemic IQ model, has about 70 billion parameters. Can you put that into context? Is that big? Is it small? How does that compare to something like ChatGPT?
Yeah, in the model we currently use has 8 billion parameters, even though we have a 70 billion version. In terms of these open source models, I would say the 8 billion is sort of the moderate size model. The 70 billion is probably the larger size. But there are other models out there that are much larger. So for instance, I think GPT-4 was on the order of probably 1.5 trillion parameters. The larger the model, then, the larger the expertise that the model has, right, the larger the corpus of data or documents that the model has been trained for. But also, of course, it is much more expensive to, even for inference, running a larger model because you need many, many GPUs. So part of the consideration was how we can also get a model that we will not need a farm of GPUs to run every single query.
And so does your model, the one that is used by the analysts every day, is that something that presumably runs on the cloud, or does it sit on your laptop, or how does it actually how do you get access to it?
Yeah, it runs on the cloud. The entire Beacon system is on the cloud, and there are a number of different components to the system. So there is the AI pipeline that runs on the cloud. In fact, it runs on AWS. And there is another system, which is the editor's workspace. So the subject matter experts, the infectious disease professionals would log in on a daily basis to that system, and they essentially see an inventory of the different things that are waiting for them to do, new outbreak reports that are coming in, decisions that have to be made, which ones need to be processed. They will also see reports that are sort of drafted and ready for them to look and review. In some instances, they would be able to generate from their own knowledge things that the AI agents may have not been able to find, so sort of manual signals that they would ask the AI to perform. And then there is a third system, which is the website and the content provider of Beacon that, again, sits on the cloud. So there are essentially these three subsystems that are communicating, and all of these systems sit on the cloud. In general, that's not something that you can run on a laptop, and particularly since it involves queries into a large language model, you need GPUs to run every query. And, also think about the scale. It may process on the order of 500, 1,000 signals on a daily basis. And there may be signals that need to be processed at the same time. So you need to be able to have access to a scalable computational resource. So on demand, when you need it, you can get access to more GPUs and run these queries.
You mentioned the GPUs a few times. If I recall, this is graphical processing units. Is that right? And are these computer chips that you have sitting in your desktop at the office, or is this part of a large computing facility? And how do you get enough of these GPUs to be able to create your AI models?
Yeah, so these are chips that are sitting in servers that are in data centers. You could get expensive desktops that have GPUs, but probably they would have at most 2 or 4 GPUs, so you cannot scale a production level system using desktops. To train the model, we were lucky with support from the National Science Foundation. We're able to get access to a cluster of 32 NVIDIA GPUs that were sitting at an NVIDIA cloud system. And then, as I mentioned, for the day-to-day operation of Beacon, the GPUs that we're using are on AWS. So they are data centers around the world that have the servers, that have GPUs. These are very expensive pieces of equipment. Well, because they are fairly large chips and very sophisticated, but also because these days everyone is trying to get their hand on GPUs for training a variety of models. So there is sort of a supply and demand from traditional economics in play. Here, just to give you a sense of how expensive they can be, these days you can get a server that has, I don't know, on the order of 8 GPUs that you can put in a data center that may cost on the order of $150,000. So this is not your standard laptop or your standard desktop that you will buy with a few $1,000s.
Well, so really, I think taking the whole thing together with the specialist skills required to train the model, even starting with a model like the Llama family models, as well as all of the computational resources, it really doesn't sound like this is something that can be done easily at the moment by groups, with moderate amounts of resources. Is that right?
This is correct, and there is also a software engineering team behind Beacon. In fact, we have leveraged the software engineering team that works at Boston Children's Hospital with the HealthMap team, with John's team, and also a team that we have here in the Hariri Institute. We have something that we call the Software and Application Innovation Lab that is an interesting concept. You can think of it as a software engineering shop within a university setting. And it has been very influential in terms of our ability to develop a production level system. So these are the people that essentially are taking some of the code that has been produced by graduate students that work in my group with the AI pipeline and make it a product, create an API, because there is an API that provides access to the system that the SMEs are using, and also to the system that provides the content of the Beacon, the website, the CMS that provides the content of Beacon. Having these groups now, I think, is really important in delivering systems of this type. And in terms of the computational resources, I mentioned the NVIDIA cloud. There is another high-performance computing center that is, in fact, shared by all of the universities in the Boston area. And BU has access to resources in that green high-performance computing center in Massachusetts. So one needs access to resources of this type, human, but also equipment, to develop systems that scale and can do apply the more sophisticated AI tools.
Yeah, I mean, it's also a really interesting example of how different professional disciplines are now all working together and actually leveraging these tools for, as you said, production level, or I guess, commercial level use. Really requires this multidisciplinary effort. I think that's a really interesting feature also of AI in general. It's not just computer science, and it's not just computational power. It's really a mixture of all sorts of different professional disciplines. I mean, I guess this is also why, we don't see too many public health specific models out there at the moment. Although, I hear from other people that they're also trying to develop specific models for public health purposes. How do you see this field moving forward in the future?
So I think you will see more and more of these models. In fact, we plan to make the model that we have developed open source fairly soon, so that others can build on top of that. And, in general, we are very much in favor of this open source movement, because it would allow others to build on. That's how science progresses, right? I think, the future will probably see more of these types of systems being developed. In many ways, LLMs in particular are sort of an equalizer, because even though there are these barriers to training this model and you need some level of expertise, now there are a variety of tools that people don't necessarily need many years in the field and a PhD to start working in this domain. but to develop models that are very specific, that have certain properties and so on, you do need the more heavy-duty expertise that PhD students could provide. I think one of the possible limitations of using more and more and seeing more and more of these models in the healthcare and public health fields is that funding. We discussed the amount of effort and the level of resources that it takes to develop models of this type and deploy them and develop production level systems. And commercial entities have not necessarily an incentive, right, to be in that field, because public health in general is not a domain that you see a lot of commercial activity. So there is, I think, a need to develop more robust funding mechanisms for funding these efforts. And there is also a need to develop, I think, infrastructure, computational infrastructure that is open. Something that we are observing is that the gap between the resources that academic institutions and other institutions that are working towards the public good and they don't necessarily have a commercial interest in mind, the level of resources that they have is not the same of level of resources that the tech company would have. And now that these computational resources are very, very expensive, there is a need of foundations, governments to fund an infrastructure that makes these resources available so that they can be used in public health and in other domains where there is not a commercial interest to develop models.
Yeah, that's super interesting, because I think that, as you say, it's not exactly a lack of human talent or human capability, but now I think we're reaching the limits of our access to computational power. And actually, I happen to be having this conversation with you from Cape Town in South Africa, and in the African continent, the access to large data servers and high performance computing is very limited. And so even with the expertise and knowledge, accessing and building models like this still remains out of reach for many parts of the world. So I think it does sound like that's going to be, at least in the short term, some of the major challenges there. So Yannis, well, LLMs, I think, offer a huge amount of potential for public health purposes. I guess they come with some strings attached. What are the kinds of concerns that your team or maybe the users of Beacon may be flagging?
Yes, and I will try to answer this in a more general setting. Because I have been involved in efforts at my institution at Boston University in providing access to LLMs to students, faculty, even staff, for performing some of their typical functions. Some of the concerns that we are seeing have to do with a number of ethical issues and implications of AI. And what we've been trying to tell students in particular is that AI is here to stay, so you cannot ignore it. You will definitely operate in a world where AI models will be prevalent, and therefore you need to be informed, and you need to embrace AI, but critically embrace AI. So I think that critical embrace stance is important. Some of the ethical issues, many people are concerned about the environmental impact of training very large models, which is a real issue that needs to be addressed. Obviously, the environmental impact is there for training very large models, not necessarily for every single user who would submit a query to an AI model. That is a minuscule amount of energy that is being expended there. In healthcare and public health in particular, AI models may accentuate biases that exist in the data. So as we have discussed, human supervision is important to diagnose and mitigate these biases, and there are some methods in place that would help you do that. I think another important consideration from particularly the perspective of students and us as educators is that over-reliance on AI could potentially be an issue. Because if, like a human TA, if you have one next to you every time, and when a question comes up, you go and get an answer, then you don't necessarily develop the brain connections that are needed to try to understand the question on your own and so go deeper in a certain subject. So I think we need to be careful, particularly when we use AI models in education, to advise students on better ways of using it so that they don't over-rely on these models. So these are some of the questions that typically come up, and I think they are important to point out.
Yeah, I agree. I think AI literacy in public health in general is a huge challenge, and I think all of us are trying to keep up and understand what some of the benefits, but also some of the challenges and downsides might be. And I guess ultimately it comes down to having better data that's representative of our communities and different parts of the world that go into these models, so that some of these biases might be minimized.
Yes, and there is, I think, these days quite a bit of effort in data curation, because essentially people have observed that you can train smaller models if you have better quality data that are used to train these models.
So what's next for Beacon? I presume that it's a process that never stops of continuing to fine-tune your model and improve it. But what about what's next on the horizon for Beacon specifically?
Yeah, as you say, continuously improving the system. What is behind what you see on the public website, but also what you see on the public website. I think in the last day or so, we enabled maps on the public website. So now when you see an outbreak report, you see a map of the area where the outbreak has occurred. Some of the things that we hope to do in the future would be to move beyond outbreak reporting and think about even predictive analytics, understanding from the data that we are now collecting what are some of the things that may lead to higher likelihood of an outbreak breaking in some area, rather than reporting what has already occurred. And also, Beacon has a mission and is working on that mission to engage with a variety of different stakeholders and make the Beacon field available to others that may want to integrate that feed into their own system. As you know, have been working with WHO for integrating Beacon into the WHO EIOS system. And we hope that will increase the use of the system, and more and more agencies and people that are making important decisions for public health will be better informed when they make those decisions.
Well, great. Thanks so much, Yannis. I really enjoyed catching up and talking again. And I really think this initiative is a real trailblazer in public health. And I think it's really one of the first really large-scale global initiatives that's especially designing and employing LLMs. So I encourage everybody who's listening to go and visit the Beacon website, beaconbio.org. We'll have the link in the show notes. And thanks so much for taking the time to talk today, Yannis.
Thank you. Thank you for inviting me, and it has been a pleasure to talk to you.
Thanks so much for joining us for this episode. We hope you enjoyed it as much as we enjoyed making it. Be sure to subscribe and share this podcast with your friends and colleagues. We'll see you next time.
The Innovation Forum AI podcast is produced by Zoila Leiva Rioja and brought to you by the WHO Hub for Pandemic and Epidemic Intelligence. We'd love to hear your feedback and ideas. Reach us at pandemichub@who.int.